Good evening and welcome to Doctors on Call. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth, and I'll be your host for our program tonight on diabetes. We will be glad to take your calls on diagnosis, complications, and treatment. The success of this program is very dependent on you, the viewer. Please call in your questions and we'll do our best to answer them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Christina Helterbrand, an endocrinologist with Essentia Health, Dr. Kim Ogle, an internal medicine specialist with Essentia Health Ashland, and Dr. Megan Underberg, a PharmD at the College of Pharmacy and Community Memorial Hospital in Cloquet. Our medical students answering phones tonight are Alice Deeden of Red Wing, Minnesota, Dutch Hansen of Dawson, Minnesota, Marie Whippler from Parkers Prairie, Minnesota, and joining them is Dr. Joy Swanowski, a PharmD who is a resident at St. Luke's Clinical Pharmacy. And now on to tonight's program on diabetes. Well, Dr. Helterbrand, I'm wondering, when people come in to see you in the clinic for their appointment, what should they bring along when they have diabetes? Just bring themselves or what?
Oh, no, it's very important for them to be prepared. They need to bring anything that they have that they want to discuss. For example, a list of questions. They need to have their medications and they need to know the doses of their medications. They should bring their glucose meter, and if they're keeping a blood sugar log, they should bring that as well. So all of those things are very important in making their appointments a success.
Great. Well, Dr. Ogle, maybe we could start out this also just by maybe explaining the difference between type 1 and type 2 diabetes. We hear these terms. What does it mean?
Sure, that's a good question. A lot of times people aren't quite so sure. So type 1 diabetes we typically think of as in children, and they are diagnosed typically at a younger age, and primarily it is the pancreas not secreting or not producing insulin to be able to control the blood sugars. And in type 2 diabetes, typically more adult onset, older patients, and sometimes more obese or having a family history of diabetes. Not all the time, but that certainly can be the case. And a lot of times they can be controlled by diet, exercise, medications, oral, and then sometimes insulin, but don't always require insulin as you would as a type 1 diabetic.
Thank you. Well, Dr. Underberg, so that means like if you have insulin, if you have to start taking insulin, are you still a type 2 diabetic?
That's a great question too. We have so many people that come in and think if they have to take insulin that either they've been a bad patient or they've done something wrong. And what it turns out is that insulin is what we all produce to make sure we cover how we use our sugar and glucose. And whether you're type 1 or type 2, insulin is often a mainstay in our therapy. So yes, if a type 2 ends up needing insulin, it's a very good thing. It actually is one of the best therapies along with pills and diet and exercise.
Okay, thank you. Dr. Helterbrand, diabetes is more than just high blood sugars, is that right? I mean, there are other problems that can occur and other things you have to look for when you have diabetes?
Definitely things that are associated with diabetes, certainly being overweight. That increases insulin resistance, which means the body doesn't use the insulin appropriately. They can also have hypertension, which is high blood pressure. Sleep apnea, I think, is very common and often overlooked. So I usually discuss with someone how well they're sleeping. And then certainly there are complications from diabetes as well that need to be addressed, and we try to help the person prevent those complications by controlling their blood sugars and their blood pressure and not smoking and taking aspirin if necessary. So
all diabetics should be on a baby aspirin then?
Not everyone. American Diabetes Association now says if you are male over the age of 50 or female over the age of 60, baby aspirin should be considered, but you should speak with your doctor and not just start it.
Okay, thank you. Dr. Ogle, so how do I know if my diabetes is doing well or not? I mean, what do you check for?
Sure. So typically people at home have the glucometer, so they can monitor their own blood sugars at home, like Dr. Helterbrand had talked about. But when they come into my clinic, I actually do laboratory tests. And a lot of times people hear about the term hemoglobin A1C. And what that is it can measure how well you're controlling your blood sugars over a 3-month time period. So we check that and we monitor that over a period of time. And that's one of the things we check, but we like to see listing of the blood sugars, how well they're controlled on a daily basis also.
So what's a good A1C level?
Yes, so a normal one runs between 4 and 6, and we'd like people that have diabetes to stay at about 7, but between 7 and 8, actually, we consider very well controlled.
Thank you. Dr. Underberg, so we talk a lot about insulin, but there's a lot of people are on pills too for it, right? And what are some of the really important medications that are used?
Probably one of the, I'd say, most popular and favorite ones, I'll look at our counterparts here, metformin. That's an excellent starting place for the majority of patients that have type 2.
Right.
And it is probably the number one we start with, especially now. We used to look more at some of the older ones called sulfonylureas, or some of the people out there might remember like a glipizide or a glyburide. And those make your pancreas actually put out a little bit more insulin. What we're finding now is the metformin is a little more effective, I'd like to say, from the pharmacy side, in helping your liver not pump out as much stored sugar or glucose, as well as an outside help your body use it more efficiently within the whole system. So that's the starting point. Then we start adding in things like Actos. It's a thiazolidinedione. Now we have some newer ones, some injectables called Byetta or Victoza, and that's helping quite a bit. Then there's always our insulin, but that goes back to injections. And there's newer pills called Januvia and, ladies, I forgot the other one.
Onglyza.
Onglyza, thank you.
Magenta, and there's several.
There's lots.
Yeah.
So
Always something
arsenal.
new.
Oh yes, and I think that's the best part is our patients have many, many alternatives to look at. So we really can make the therapy work best for them. It's not a one-size-fits-all anymore.
Sure, all individuals, right?
Correct.
Dr. Hildebrand, here's a couple of questions, actually kind of related to each other, but one of the questions is from Proctor is, what's a borderline diabetic or prediabetes?
Borderline is an older term. Now we use the term prediabetes, and it depends on the glucose levels. Typically, as she mentioned, A1Cs normal are less than 6%. Prediabetes or borderline diabetes would fall between 6 and 6.5%. And then type 2 diabetes or type 1 diabetes over 6.5%. And then we can also use glucoses to determine whether or not someone has diabetes or prediabetes. So there are certain criteria, whether the person is fasting or if they've taken a glucose tolerance test. So it depends on how high the blood sugar is and where they are on that scale, whether the glucoses are normal, fall into the prediabetes category or the diabetes category.
So do pre-diabetics turn into diabetics?
Potentially, yes, but
not always.
Not always, no. Diet, exercise, we can use medications to treat prediabetes like metformin, but they did a study on that and exercise actually works better. So
Excellent, yeah, I saw that. Dr. Ogle, here's a good question here from Haskell is, why do many severe diabetics end up having legs amputated?
Sure, that's a very good question. I think it's something that people probably worry about almost more than anything with diabetes. And it comes back to really controlling your blood sugars and as we had talked about, keeping that hemoglobin A1C at a nice low level. But what would happen is there can be, as a complication, injury to the nerves that go down to the feet, and people will have some numbness or they aren't able to feel their feet. And what can happen is they can have some injuries. They could have a blister or a sore that they aren't able to feel, they aren't able to, or may not be treated. And if that happens, it can become more and more of a problem, a bigger and bigger infection, and sometimes not able to be treated by medications. And then unfortunately there are times where people have to go through amputations. But I really feel that we can do a really great job controlling diabetes now. We talked about a number of the different medications and insulin, and I like to think that we really are eliminating having people have those ulcers that result in amputations in the future.
Thanks.
and if I could add,
Please.
don't smoke.
There
if
you
you
go.
want to keep your limbs, don't smoke.
Yeah, very good. Dr. Underberg, here's a patient from Two Harbors, a caller from Two Harbors, has microalbumin in the urine and was started on lisinopril. Is that common?
Actually, it is, and I know we're going to hear from the other team members here as well, but lisinopril is a family of blood pressure pills called ACE inhibitors, and I know a lot of our patients out there with diabetes are started on an ACE inhibitor or a very closely related one called an ARB, an angiotensin receptor blocker, and those work actually in the kidneys not only to control blood pressure, but they actually protect the kidney and how well it filters your blood. That in turn also looks at this concept they talked about, the microalbuminuria, which is a protein, and there can be changes in diabetes where the kidney starts to leak some of that and we start to see it come out in the measurements. What ACE inhibitors or ARBs can do is help protect that kidney so it's less prone to happening, or at least prolong the extension of that kidney being a healthy organ.
So you may end up on a blood pressure pill, even it's not for the blood pressure. It's
Correct.
Even, you may not have high blood pressure, but to protect the kidney.
Protect the kidney, and then if you happen to develop high blood pressure, then we can tinker with that dose to make sure it hits both things at once.
Here's another question, Dr. Hildebrandt. What is gestational diabetes?
Gestational diabetes is simply diabetes that's diagnosed when someone is pregnant.
And does that turn into regular diabetes, or is that something that a lot of times will go away when the baby's delivered?
It typically goes away at delivery, but those people are at increased risk for developing diabetes, so we usually do a screen 6 weeks after the baby's born to make sure that everything is still okay.
Oh, okay. Dr. Ogle, here's a caller from Superior. If a person with type 2 diabetes has a gastric bypass for weight reduction, will that reverse the diabetes?
It won't reverse it, but it very well will likely lower their blood sugars where they may not need to have as many medications or any medications. I actually have a patient that was a diabetic, went through gastric bypass surgery, lost a large amount of weight, and now does not need any medications. So
he's still diabetic, but
well controlled now. Absolutely, yeah. So that was very nice to see.
Great, great. Let's see. Just going through some of these. How does here's a question for Dr. Underberg. How does hypoglycemia relate and hyperinsulinemia relate to getting diabetes? Do you know that? That's kind of a hard one.
That's a complicated one. There's a couple concepts there. I know there's, we could look at this way and then you ladies chime in
please,
as well.
anyone can answer,
So
sure.
there are some patients that have said, as a child or a young adult, I often had low blood sugar, very, very low blood sugars, and then as they age, they find out they develop diabetes. So there's often has been that question from those patients, what was that relationship to me having an overproduction of insulin and those lows as throughout the lifetime, and then turning diabetic, which is not the best phrase to use. And there is that question, did the pancreas to an extent wear out? And I think I'll turn to some of my counterparts at this point and say, what is your professional opinion on, can that happen? Can you wear your pancreas out? This is a hard question.
It is hard.
The way I would typically explain this to someone, if they've had difficulties with low blood sugars in the past and they were not on medication that would have caused that, I say the pancreas is a little confused. If the body takes in carbohydrates based on the content of the meal, the pancreas may be confused as to how much insulin to put out and when, and so that may not necessarily match up with the absorption of the food and can cause some low blood sugars. Typically, we see that when someone eats a lot of carbohydrates at once. So the blood sugar rises, and then it will fall later on, and then they can develop diabetes later in life.
Thank you.
And I would just add, when patients hear that term hypoglycemia or hyperglycemia, the hypo is low blood sugars, and that can be very dangerous. So when people are on medications, we do have to warn them or ask them to really watch that, because that can cause complications as well. So low blood sugars would typically be below 60, and that could be quite dangerous.
Here's a question sort of on the same lines. We're talking about what are the consequences of taking metformin and Lantus together? Is that a common combination?
Sure. Yes, we do that. the metformin can work certain ways, and then the insulin also helps as well. And so that is something that we will do together on a regular basis.
Dr. Underberg, how about as far as medications go? Do type 1 diabetics, are they on pills too? Or is that all insulin?
Typically, type 1 diabetics, we rely on insulin as they aren't able to produce enough to cover what they consume for the glucose. There is a total deficiency of insulin production. So type 1s typically are pretty well maintained on insulin therapy. That's not to be said they won't have the other oral therapies to help out the other potential complications of diabetes, so like the ACE inhibitor, the aspirin, any control of a cholesterol condition that might be coexisting at the same time. So as for oral hypoglycemics or oral medications for lowering blood sugar, typically we reserve those for the type 2s.
Sure. Thank you. We have a couple of questions here, Dr. Hildebrand, regarding what blood sugars are considered normal, and when do you think diabetes can be diagnosed?
Normal blood sugars in the lab are different from the goals that we use when someone is checking their blood sugar at home. So if someone were to go into the lab, a normal blood sugar would be 70 to 99 if they are fasting. 100 to 125 would fall into the prediabetes range, and 126 or higher would be consistent with diabetes. If you're checking your blood sugar at home, then we like to aim for a morning blood sugar between 70 and 130.
Okay. Thank you. Well, that answers a couple of those questions here. Dr. Ogle, is type 2 diabetes hereditary?
You know, it can run in families, so we sometimes think of it as that a hereditary type of thing. So it does run in families, and sure, I think we could consider that.
Dr. Underberg, we've talked about insulins. There's different types of insulins, right? There's some that are long-acting, some that are short-acting?
There's actually some very exciting insulins. So the older insulins were sometimes even mixed. So we used to have pork and beef insulin. Those were the first two we had, and a lot of patients out there were on those. Very good when we didn't have anything. So to even have the advent of insulin, it was huge. And then we moved into mixed ones where some patients would take 2 shots instead of multiple shots. That would be an NPH type. And now what we love are very short-acting ones like Novolog and Humalog in conjunction with the basal insulin, a long-acting one over the course of 24 hours, which is called Lantus. And we're seeing amazing results with our patients, having very, very wonderful control and having a very closely mimicked style that the pancreas naturally does, but we just supply it from the outside.
So how big is the insulin needle? Is it that big?
It's not a horse needle. It's not even a cattle one.
Okay.
They're beautiful. They're very, very short. They're tiny right now, and they're extremely sharp and fine-tipped. So most of our patients, we find when it's getting over that first initial injection into the tummy, and once they do that, they don't notice the poke of the needle, but instead more the insulin going in, often because it's cold. But the needle itself is very, very short and very, very sharp. It's coated, so it slides right through the skin. It's
Yeah,
beautiful.
there's a lot of hesitancy, but when patients actually do it for the first time, they go, well, that wasn't much.
Wasn't
that was
bad at all,
easy."
was it?
It's more to stick your finger.
It does.
That's
true.
true.
I agree. Lots of times I have patients tell me that that last thing they want to do is be on insulin, and they try with oral medications and diet and exercise, and then actually if they start the insulin, they really find that they feel a whole lot better. It's much simpler, and I really do encourage, and it's much safer, I think, in many ways in avoiding complications. I had one patient that came back after starting insulin, said he's felt best that he's ever felt in his entire life.
Wow, great. So how do diabetics feel if their blood sugars consistently run high, like a type 2 diabetic? I mean,
They may not notice anything.
so they could be just asymptomatic.
They could be just fine and not notice a thing. They might be tired and not really realize how tired they are. Some of the more common symptoms when someone is getting into trouble, though, would be thirsty all of the time, urinating a lot, and then if they're really getting into trouble, abdominal pain and nausea and vomiting that can end them up in the emergency room.
Thank you.
That's more typically with someone who has type 1 diabetes. So.
Sure. So Dr. Ogle, why do some people end up on pumps? What's that all about? Insulin pumps.
Sure. Typically, that's our type 1 diabetics, and it's a finer control or a little more control of those blood sugars where they're able to dial in how much insulin that they're going to supply themselves. And we typically, I believe anyway, reserve it for type 1 diabetics.
I have several with type 2.
As well? Okay.
A lot of it depends on the insurance. Medicare, for example, will not cover an insulin pump for someone with type 2 diabetes. So it does depend on their insurance.
Sure.
Usually.
Dr. Underberg, here's a question. I have bad kidneys. Are there diabetic medicines I shouldn't be on?
That's an excellent question, and this does come up because we know one of the complications with diabetes are changes to your kidneys due to the different problems with diabetes. We do start to watch with metformin, one that we talked about as our mainstay, and when your creatinine starts to rise, and a lot of patients with diabetes know these numbers great, we watch on men and women a 1.4 and a 1.5. We start to become quite cautious and, number one, reduce the dose or stop the drug entirely. And then we also have to watch on some of those glycerides and glipizide types because they're cleared more slowly, which could result in you having lows because you can't get rid of the medicine.
Thank you. We have a question, a caller from Duluth who's had type 2 diabetes just for 2 or 3 weeks, and she's really having troubles eating with vomiting and whenever she eats or drinks something. What could be going on there? It could be something. Can diabetes affect the stomach, I guess would be a question.
One of the issues with diabetes is that the nerves that affect the emptying of the stomach can be affected, and then the stomach emptying is slowed down, so people can have difficulty with swallowing, and they have difficulty with nausea and vomiting. And that would be more of an acute, more of a sudden issue in someone who has only had it for 2 or 3 weeks. So I would be concerned that their blood sugars were running quite high. If they're not running quite high, then I think other things need to be looked into. And perhaps medications. Metformin can cause nausea and vomiting. So if they got started on metformin, then that would probably be the first thing I would look at.
Dr. Ogle, we have a question here. How does diabetes affect the eyes? Why are we always telling our diabetics, I put that in, why are we always telling our diabetics to get their eyes checked?
Right, because that can be a complication of diabetes. Again, high blood sugars can affect blood vessels, and so the blood vessels to the eyes can get swollen, they can get leaky in the eyes, and can cause vision changes. And in the early stages, we may not know that is affecting our eyes or could be affecting the long-term eyesight. So we ask our patients to go to the eye doctor and get a dilated exam by an ophthalmologist once a year just to make sure we're controlling and watching for any changes.
Very good. A question here about the dawn phenomena. Anyone want to answer that one? We'll throw that out there.
Go ahead.
Dawn phenomenon. Typically you have a plunge. I hope I'm remembering this right. A plunge or a jump?
A rise.
A rise in your Samoji effect is the other one we sometimes hear of your glucose. And the way I've always looked at it is your liver is very smart and it senses when you need energy. So sometimes early morning it dumps and it says, you need food. Here's some food. But it really concerns a patient because all of a sudden you have these high fasting numbers. And what do you do about it then? Well, we have to take a look and adjust medications and or even change how a person might have a snack before bedtime to allow the body to adjust for that.
Very good. Thank you. Dr. Hildebrand, could a glucose tolerance test lead to an elevated glucose level several days later? How long does that effect last?
If someone has diabetes, it could. That would be consistent with a high glucose. Otherwise, the test itself, if the test was normal, I wouldn't expect high blood sugars several days later because that person wouldn't have diabetes if the test is normal.
So that could indicate that the patient does have diabetes? Or
it could, yes.
It depends. The whole test has to be read, of course.
Yes, I'd expect
exactly
the test to be abnormal and then then
Right.
that would follow.
And Dr. Ogle, maybe our last question here, is someone with cirrhosis of the liver, are they susceptible to diabetes too?
Well, you know, that they can go hand in hand, not necessarily susceptible to it, I don't believe, but I think we need to really watch different medications when there's liver disease, and there are a lot of different complications and different complexities that need to be addressed with the physician.
Sure. Thank you very much. Well, I'd certainly like to thank our panelists tonight. Dr. Kim Ogle, Dr. Megan Underberg, and Dr. Hildebrand, and our medical students are Alice Deeden, Dutch Hansen, and Christy Nowak, and Dr. Joy Swanowski. There won't be a program in the next 3 weeks due to Thanksgiving and a pledge week here at the station, so please join Dr. Ruth Westra for a program on December 15th. It'll be on high blood pressure, when her panelists will be Dr. Krista Christian, Dr. Ryan Harden, and Dr. Mike Swanowski. Thank you for watching, and good night.